Welcome everyone to today's webinar, Setting Up a Successful Lung Cancer Screening Program, Key Considerations. I'm Aaliyah Pavla with Becker's Healthcare. On behalf of Becker's, thank you for joining us today. Before we begin, I'm going to walk through a few quick housekeeping instructions. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We are here to help. And with that, I am pleased to welcome today's presenters. Dr. Christopher Lee is a thoracic radiologist at Cedars-Sinai Medical Center. A native of California, Dr. Lee received both his undergraduate and medical training at the University of California, Los Angeles. Dr. Lee remained at UCLA for his diagnostic radiology residency and thoracic imaging fellowship before moving across town to become a faculty member at Keck Medicine of USC. While at USC, he was Associate Professor of Clinical Radiology, Director of the Cardiothoracic Imaging and Intervention Fellowship, and Director of the USC Lung Cancer Screening Program. Dr. Lee has been at Cedars-Sinai for the past year, where he has been working with hospital leadership and stakeholders to develop a lung cancer screening program. We also have Dr. Stephanie Kennedy Ray, who leads the Office of Cancer Prevention and Control, which is the community outreach, education, and population-based research arm of the West Virginia University Cancer Institute. She oversees several funded programs aimed at decreasing the cancer burden in the state. Her areas of focus include cancer health disparities, health literacy, breast, cervical, lung, and colorectal cancers, and reaching rural underserved populations. The West Virginia University Cancer Institute and West Virginia University Hospitals are collaborating with Canon Medical Systems and the Lung Cancer Initiative at Johnson & Johnson to reduce the impact of lung cancer in West Virginia by promoting earlier detection and awareness, which supports the collective mission of these organizations. Thank you both for being here today, and I will now turn the floor over to you, Dr. Lee.
Hello, my name is Chris Lee. I'm a thoracic radiologist at Cedars-Sinai Medical Center, and today I'll be speaking about lung cancer screening with low-dose CT key considerations. I want to thank Becker's Hospital Review and Canon Medical for hosting and sponsoring this webinar, and I want to thank Adele May, who was previously my colleague, now with Canon, for her assistance in some of these slides. I do disclose that I'm a member of the Speaker Bureau for Canon Medical Systems. And here's my outline. I'll first go over the role of CT in lung cancer screening, then talk about the current adoption of lung cancer screening. I'll then spend some time on the implementation of low-dose CT lung cancer screening, and finally end with a lung cancer screening image review. So what is the role of CT in lung cancer screening? Well, as we all know, lung cancer is a huge problem. In 2018, an estimated over 150,000 people died from lung cancer. Lung cancer is a leading cause of cancer deaths among men and women, accounting for nearly a quarter of all cancer-related deaths. According to the current CMS guidelines, there are approximately 8 million Americans who qualify as high risk. And what's always a sobering statistic whenever I hear it is that lung cancer creates more deaths than breast cancer, pancreas, and colon cancer combined. So the story of lung cancer screening with low-dose CT started with the National Lung Screening Trial. which was a massive undertaking across the United States where they enrolled over 50,000 participants and they randomized them to either a low-dose CT arm or conventional chest X-ray arm. These participants were between the ages of 55 to 74 years of age, had at least a 30-pack-year smoking history, which means 1 pack a day for 30 years, or 2 packs a day for 15 years, or some other combination, and were either current smokers or former smokers who quit within the past 15 years. The NLST published the results in New England Journal of Medicine in 2011, so 10 years ago now, in which they demonstrated a reduction in lung cancer mortality of 20% in the LDCT arm compared to the chest X-ray arm. More recently, the European Nelson trial published their results in the New England Journal of Medicine last year. They had a slightly smaller trial, enrolling almost 16,000 participants. Trial participants were between the ages of 50 to 74, so a little bit younger, were current or former smokers who quit 10 or fewer years before screening, and had a smoking history of roughly 20 pack years or more. So a slightly smaller, lower pack years. And the researchers tracked these participants for at least 10 years following the baseline exam. And in that follow-up period, they demonstrated a 24% reduction in mortality among men and 33% reduction among women. They also showed that almost 59% of those who were diagnosed with lung cancer were in early stages and thus eligible for treatment. So on the backs of these 2 trials, as well as some other studies, we know now that early detection of lung cancer plays a significant role in the survival rates of these patients. Without early detection, the 5-year survival rate for lung cancer is only about 19%. Only 16% of lung cancer cases are diagnosed in an early stage, and more than half of those diagnosed with lung cancer will die within a year. With early detection, however, low-dose CT scanning can decrease mortality rates by at least 20% among high-risk populations. And 5-year survival rate for lung cancer detected in an early stage increases to 56%. So who's at risk? Well, according to the Centers for Medicare and Medicaid Services, they pay for lung cancer screening, low-dose CT, in patients who are between the ages of 55 to 77 years, who smoked at least 30 pack years, just like the NLST, and were either current or former smokers who quit within the past 15 years, just like the NLST. In addition, there are some other elements that must be met for CMS to reimburse for these scans. One is that patients must participate in a lung cancer screening, counseling, and shared decision-making visit. A written order for low-dose CT lung cancer screening must be provided by a physician or a non-physician practitioner, such as an NP or a PA. Low-dose CTs must be reported utilizing a standardized lung nodule identification, classification, and reporting system, such as ACR lung rats classification system. And low-dose CT data must be submitted to a CMS-approved registry, and the only one that is currently approved is the ACR Lung Cancer Screening Registry. Now, CMS is currently considering an update to the National Coverage Determination, which will hopefully be released early next year. The USPSTF, or United States Preventive Services Task Force, first came out with their recommendations in 2013. And those are very similar to the CMS recommendations. However, earlier this year, they revised their recommendations, and namely, they revised the age and pack years. So they expanded the age range of 50 to 80 years. Previously, it was 55 to 80 years, and they reduced the pack years from 30 pack years to 20 pack years. Patients must still be a current smoker or a former smoker who quit within the past 15 years. Now, the USPSTF recommendation is important because under the Affordable Care Act, most private insurance plans are mandated to pay for lung cancer screening as a covered benefit due to the Grade B recommendation that was issued by the task force. Now, with these new recommendations, they may not be covered until potentially January 2023. So until then, commercial payers may voluntarily expand their coverage, but they may impose cost sharing on the patient. The National Comprehensive Cancer Network has also recently revised and simplified the recommendations, with only age and pack years as the only criteria. So at least 50 years of age and at least 20 pack years smoking history. They have eliminated the cutoff for former smokers. So it doesn't matter now when you quit, according to the National Comprehensive Cancer Network, or NCCN. What is the current adoption of lung cancer screening? Well, I think we all know that it's not very good. In the American Lung Association's State of Lung Cancer report that came out just last year, only 6% of those across the nation were of those at high risk were screened. So a very, very low rate. You can see here, based on this chart, this is a state-by-state breakdown. Massachusetts has the best screening rate at almost 19%, while Nevada has the worst at 1%, and California, where I live, is the second worst at 1.2% of those at high risk who have been screened. So there are a number of barriers that account for lung cancer screening not seeing the same adoption as other screening modalities like breast cancer screening, colorectal screening, and prostate screening. I think education is probably the biggest barrier. Both the NLST and Nelson trials have made tremendous strides to eliminate the benefits of screening for lung cancer. However, many people are still not aware of these trials and of these recommendations. So there is a lack of education for these 8 million, and actually now with the new USPSTF guidelines, almost double that, about 15 million high-risk Americans that need to get screened, and so education is still a major barrier. The cost of screening and downstream workup and treatment can also be a barrier, and it may be prohibitive to some of those at high risk, especially those that are underinsured or uninsured. And location is also a barrier. The geographic isolation of some rural communities and their limited access to screening facilities has also proven to be a barrier for lung cancer screening uptake. Furthermore, lung cancer screening is unique in that it is the only screening modality in which individuals are referred based on their association with a very highly stigmatized and publicized risk behavior. And this stigma has engendered attitudes of fear, avoidance, and even fatalism among smokers, and especially those from minority disadvantaged backgrounds. So these people may not want to present or talk about screening with their physician because they feel like they'll be judged, as they've heard over and over again that lung cancer is a disease that they brought onto themselves due to their smoking history. And so the Lung Cancer Alliance, now known as the Go-To Foundation, tried to address this stigma a number of years ago with a series of these advertisements that they posted around the nation, trying to address the stigma. And so it was I think a very potent campaign, but we still have a long ways to go. So I'll now talk about the implementation of low-dose CT lung cancer screening. And so here's a depiction of the patient's journey through the entire lung cancer screening process. Initially, eligibility must be determined. Again, not everybody at a certain age can get a lung cancer screening study like they can get a colonoscopy, or any female of a certain age can get a breast cancer screening study. The PAC years needs to be ascertained, and also if the patient is a former smoker, that person must have quit within the past 15 years. Following that, especially if the exam is going to be billed to Medicare, a shared decision-making consult must take place in which the patient meets with the ordering physician or perhaps a mid-level provider, goes over the benefits and risks of lung cancer screening, discusses smoking cessation, and only after that takes place can the physician or the ordering provider submit an order for the low-dose CT scan. Then the scan is scheduled, and the patient goes to the imaging facility and undergoes a low-dose CT. Following that, the radiologist will look at the images and generate a report utilizing the ACR lung RADS classification. Then this report goes back to the ordering physician and communicated to the patient. And if there are any follow-up studies that need to be ordered, such as a short-term interval follow-up CT scan for an indeterminate or suspicious nodule, or some other imaging study for a significant incidental finding that was discovered in the CT scan, those must be handled during this discussion and the subsequent orders placed. And so there are a number of steps that need to take place. It's not entirely a quick and easy process. And this is where a navigator of a lung cancer screening program can be quite valuable and really assist in guiding the patient through this process and also communicating the results to both the patient and the ordering provider. Well, what about the economics? Well, as I mentioned earlier, Medicare does pay for these scans according to their 2015 decision coverage memo, but there are requirements. Again, the patients must be at high risk. The current guidelines criteria are still ages 55 to 77, asymptomatic, minimum 30-pack year smoking history, and either current smoker or quit within the past 15 years. Again, these criteria are under review currently, and hopefully we'll have an update by early next year. But these are still the current criteria. Again, all these other elements need to be met for CMS reimbursement, so the patients must participate in a counseling and shared decision-making visit, and the lung cancer screening data must be submitted to the ACR Lung Cancer Screening Registry. As you can see here, the reimbursement per scan is not very high. And so if you take into account all the things that need to be set up for a proper lung cancer screening program, such as hiring a navigator or purchasing software that will allow and assist in following these patients, many medical centers and facilities consider lung cancer screening as a loss leader and really are expecting that downstream revenue will be generated from things such as additional imaging or workup or treatment of lung cancer itself. The good news is that most insurance plans pay for screening. Here are the different types of plans that are out there. I talked about Medicare and their current coverage requirements. And again, there's no cost sharing to the patient, so there should be no copay or deductible. Patients who have either an employee-sponsored plan or a plan purchased on the state insurance marketplace also get lung cancer screening provided, covered, and mandated under the Affordable Care Act with no cost sharing to the patient. These are the current coverage requirements. You'll notice that these are different than the current USPSTF guidelines. These are actually the original USPSTF guidelines that came out in late 2013, early 2014. And it's not until at the earliest March of 2022 that these insurance companies will be required to adjust the requirements to cover patients at a younger age, down to age 50, and a lower pack years down to 20 pack years. Again, until then, commercial payers can voluntarily agree to cover the new USPSTF criteria, but they're not required. Now, if you have an individual plan, oftentimes those are also covered by lung cancer screening is also covered, but it does vary, and it's recommended that you contact your insurance company for further details on that. And Medicaid varies state to state and plan to plan, so it is also recommended to contact your individual carrier for that. The American College of Radiology and Society of Thoracic Radiology published a practice parameter a number of years ago for the performance and reporting of lung cancer screening CT. And so in this parameter, they made the following recommendations: that low-dose CT should be performed using multi-detector helical CT with a gantry rotation time of less than or equal to 0.75 seconds, using a CT scanner with at least 16 rows, slice thickness less than or equal to 2.5 millimeters, although 1 millimeter or less is preferred for small nodules. Of course, this is a scan that's performed without intravenous contrast. And the CTDI vol should be less than or equal to 3 milligray for a standard size patient. So really, these are not very difficult criteria to meet. Pretty much any modern scanner nowadays should be able to perform a low-dose CT. Now, when setting up your CT protocols, I recommend that you check out the American Association of Physicists in Medicine website, in which they have actually created standardized protocols for all the various vendors out there. So if you just go to the AAPM website, you can find these standardized protocols and then program them into your own individual scanners. Now, the American College of Radiology, as we all know, offers accreditation requirements for medical imaging. They also offer an ACR lung cancer screening center designation. That's not required. It's really optional because unlike with breast cancer screening, there is no current MQSA equivalent in lung cancer screening that requires all lung cancer screening facilities to be accredited. ACR also, as I mentioned before, houses the lung cancer screening registry, and the data must be uploaded to them for CMS to reimburse for these scans. So when building a lung cancer screening program, I highly recommend that it be done in a structured approach. And so these are my key components I believe are necessary when building this structured screening program. And the first step really is to collaborate with clinical stakeholders and your hospital administrators to create a multidisciplinary team. This team should include, at a minimum, radiology, thoracic surgery, pulmonary medicine, and ideally medical oncology, and radiation oncology. And this team should also have a nurse navigator. And really the nurse navigator is the person that drives this program, as they were the one that interfaces with both the referring physicians as well as with the patients, and really guides them through this whole screening process. The second step, and I think is a very important step again, is to educate, and we not only need to educate the patients, but also educate the primary care physicians. As a lot of physicians out there still are not truly aware of the lung cancer screening recommendations. There are a number of decision aids out there, both in paper form or those that you can find on the web. A really good one out there is shouldiscreen.com. And so this can be used by physicians or the navigators within the clinic to see if somebody qualifies for lung cancer screening. There is good news in that the American Academy of Family Physicians, or the AAFP, initially they put forth a statement stating that they did not recommend lung cancer screening, but they recently revised this recommendation and now endorse lung cancer screening. Third, you really want to streamline the ordering process, and by that I mean create both electronic and paper order sets and forms that have the necessary elements that can be checked off to make sure the patients are eligible for lung cancer screening, and that these scans will be reimbursed by CMS and insurance. In this process, as a program, you also want to think about whether you want to have a centralized program in which all the ordering and follow-up is performed from the center through a lung cancer screening clinic, a decentralized program, which means basically referring physicians can order these scans and they'll also be responsible for the follow-up, or maybe a hybrid program in which referring physicians from anywhere can order these scans, but then follow-up management will be performed in a centralized manner. The fourth step is to identify smoking cessation resources, and in fact, one of the CMS requirements for screening facilities is that they provide resources on smoking cessation to the patients. Then you also want to create and update your low-dose CT scan protocols. Again, I recommend the AAPM website for their standardized protocols across all the various vendors. And the radiologists also want to create their LungRads reporting templates that utilize the ACR LungRads classification system in reporting the scans. Finally, programs need to consider what kind of data they want to collect for quality improvement. Some of the elements that they might want to consider are the number of surveillance and diagnostic imaging tests, number of non-surgical and surgical biopsies, including those done for malignant and benign nodules, procedure-related adverse events, number and details of cancer diagnoses, including such details as histology and stage, treatment and survival. And so those are really the key elements I believe should be followed when creating a structured lung cancer screening program. Now, in the remaining time that I have, I want to go over some cases and really demonstrate with these images the quality or level of quality that you can expect from lung cancer screening low-dose CTs, and really we can achieve very acceptable image quality with extremely low doses. And dose is important because now, especially with the new revised USPSTF guidelines, where you can start screening as early as 50 years of age, patients may potentially get 30 years of at least one CT scan a year. So I think it's definitely a concern for a lot of people. Now remember that CMS requires that lung cancer screening CTs are performed with a volumetric CT dose index of 3 mg or less for standard sized patients. However, as we'll see in these cases, due to improving reconstruction algorithms, and particularly with the assistance of artificial intelligence and deep learning, we can actually produce diagnostic images at radiation doses that are far less than the standard within CMS's National Coverage Decision Memo, and also that outlined in the ACR-STR practice parameter I showed earlier. And so here's the first case. And on the image on the left, you can see this is a routine chest CT that's been reconstructed with something called hybrid iterative reconstruction. And that's basically the previous generation iterative reconstruction that's been in place for about the last decade or so. You can see here that this scan was performed with a CTDI vol of 3.5 milligray and an effective dose of 1.7 millisieverts. So this is even though this is a routine chest CT, the dose is quite low, almost approaching that of a low dose CT. You'll notice the patient is pretty skinny, but a lot of this is also achieved through the use of iterative reconstruction. In the image on the right here, we see a low dose CT that has been reconstructed with the newest generation algorithm called deep learning reconstruction. That's now available from a couple of the CT vendors. And so you can see here that the CTDI vol is 1.4 milligrams. That's about 40% dose of the routine chest CT on the left. But the image quality is quite comparable and possibly even, one might argue, a little bit better in the low dose CT reconstructed with deep learning compared to the previous generation hybrid iterative reconstruction. And then here's an example of an ultra low dose CT, and comparing that again to a routine chest CT. So again, this is a routine chest CT with 3.5 milligray CTDI. On the right here, we have an ultra low dose CT reconstructed with deep learning, and now we're at 0.6 milligrays. So this is half the dose of the low dose CT that we saw on the previous slide, and less than 1/5 the dose of this routine chest CT. And again, the image quality is quite comparable and perhaps a little sharper here. You can see on these blown up portions of the lungs that maybe it's even a little better. Despite the fact that this is ultra low dose CT, the deep learning reconstruction really helps eliminate or significantly reduce the noise. Here's another comparison of what we have low dose CT. Actually, this is a scan that was performed with 2.4 milligrays. So this is a low dose CT scan that was reconstructed with the previous generation hybrid iterative reconstruction on the left and deep learning reconstruction on the right. And again, zooming into these areas in the right lung, you can see that the image quality is significantly better on the image reconstructed with deep learning, where you're getting basically almost elimination of the noise, and you can much clearly see the architecture of the lung without that noise on top of it. And even this example, this is now another ultra low dose CT, 0.5 milligram CTDI vol, and reconstructed with hybrid iterative reconstruction on the left and deep learning on the right. And even at ultra low dose levels, you can appreciate a noise difference. Standard deviation is 57 using hybrid iterative reconstruction and only 45 using deep learning reconstruction. So again, even at these extremely low dose levels, there's still a reduction in noise in using deep learning. And here we have a case of an ultra low dose CT. CTDI vol here is 0.5 milligray, reconstructed with deep learning reconstruction. And you can see the image quality here is very good. And it clearly shows two tiny nodules within the right lung. So I think really this is the future of lung cancer screening. As our scanners and and reconstruction processes improve and improve, we are seeing doses routinely less than that of mammography and even approaching that of plain chest radiographs. And so to conclude, I hope it's quite evident to everyone that's listening to this webinar that lung cancer screening with low-dose CT should be offered to those at high risk. Now, the definition of high risk is a bit of a moving target due to constant revisions to recommendations by the USPSTF and the current drafting of a revised CMS statement, hopefully to be expected early next year. I think also I've shown that lung cancer screening is a complex process that is best performed really in a structured fashion. There are a lot of elements that need to be met for reimbursement, particularly with CMS. And I think the nurse navigator really is a key central piece in really tying all the elements and all the steps of lung cancer screening together, as well as guiding the patient through the process and communicating with both the patient and the ordering provider. And finally, as I've shown with the images at the end, improving CT technology, I believe, will allow us to perform lung cancer screening in the near future at extremely low doses. Again, should be less than mammography and even perhaps one day approaching that of chest radiography. So I think for all these reasons, this is a very exciting time to be involved in lung cancer screening. And with that, I thank you for your time.
Thank you for that wonderful presentation, Dr. Lee. I will now turn the presentation over to Dr. Kennedy Ray.
Good afternoon. I'm Stephanie Kennedy Ray from West Virginia University, where I direct cancer prevention and control for our Cancer Institute. I have no significant disclosures for this presentation, and I'd like to thank Canon Medical Systems and the Becker Review for the opportunity to speak. Let's start with some context. Who are we? We are a small, primarily homogeneous state that is rural, made up of 1.8 million people. 65% of those folks live in communities of less than 2,500, and our largest city is 50,000 individuals. Prior to COVID, on any given Saturday at Mountaineer Field, there were more people cheering on the football team than reside in our largest city. Building on our Appalachian values, the Cancer Institute's mission is to provide excellent cancer care to our patients and their families while strengthening our research, education, outreach, and service programs to address cancer health disparities. And there is no greater disparity in our state than lung cancer. Increasingly, our focus is on providing care close to home. We are achieving that through developing a regionalized system of care and developing mobile screening programs. Our mobile journey began in 2009 as a result of a philanthropic gift from the Statlers to honor Joe's mother, Bonnie Wells Wilson. During that last 12 years, we have screened more than 23,000 women in all 55 counties of our state, using the most up-to-date technology and fulfilling that mission of reaching people close to home. Building community partnerships through a focus on communication, trust, and successful collaboration has actually resulted in 150 community clinics that partner with us for mobile screening. And most of those clinics reside outside of the WVU medical system. I thought it might be interesting to share some of the lessons learned in mobile mammography that we'll be applying to the implementation of LUCAS, our lung cancer screening program. First of all, I think it's important with mobile that you plan for everything, but expect the unexpected. And just when you think you have things figured out, something unexpected pops up. As an administrator, one of the worst things that you'll experience is a picture of staff on ladders cleaning snow off of the pop-out so that they can get ready to move into the next system when we had a freak snowstorm in October. Beautifully sunny day in the northern part of the state, unexpected snowstorm in the southern part of the state. We've dealt with floods, and most recently we've dealt with the pandemic and the additional first pause in screening, and now the additional protocols for cleaning slows down the way we're able to put patients through. But really, when you don't have backup staff and you're out on the road, you have to plan for the unexpected and you have to be ready for anything. Secondly, we all have to learn the state and federal Department of Transportation rules for operating large vehicles, but more importantly, the rules that apply to staff time. Our drivers serve as the registers for the patients when they come onto the mobile screening units. And so there are all kinds of rules and regulations about the amount of time those drivers can drive, work, and must be off a certain number of hours in between services. Assessment is part of running a mobile screening program. All the time you want to engage and assess your patients and improving patient care. But as important is assessing the needs of our partners, being responsive to those needs, and understanding that without our primary care partners and the referring clinics, mobile screening isn't even an option. So we have to be responsive to them. I think that we all have to consider, based on the social determinants of health, the needs of patients. But in mobile, we really work to address the needs of the uninsured patient. We do this because we don't turn away anyone because of an inability to pay or a lack of health insurance. We've addressed that through philanthropy and grant writing, but I do think that it is an issue that has to be addressed by anyone who's considering running a mobile program. And then this goes without saying, but I'm going to say it anyway. You want to conduct pre-visits at all your sites. Pragmatically, you want to do this so that you know where to park the vehicle. You have to think about what the clinic parking lot is going to look like on a visit day. But more importantly, you want to work with the clinics to make sure that the patient flow works for both your workflow and what's happening inside the clinic. Fortunately, we've taken all of these lessons learned, plus the many more, from the Bonnie's Bus experience and applied that to lung cancer. Some of you may be saying, why lung cancer and not others? So I thought I'd just share that lung cancer accounts for about 18% of new cancer diagnoses in West Virginia, and 74% of those are diagnosed at regional or distant metastasis. More West Virginians die of lung cancer than of breast, colorectal, prostate, and cervical cancers combined. And we know that regular lung cancer screening will allow us to diagnose cancer at an earlier stage when it's easier to treat. But in our state, we actually only have 17 of our 55 counties that have an ACR accredited lung cancer screening program. There are currently more than 200,000 people eligible for lung cancer screening in the state. So if you combine these factors, a lack of access to ACR accredited sites denoted as yellow dots on this map, the late stage percentage of people diagnosed, then mobile lung cancer screening really is an answer that will help us change the trajectory of lung cancer in our state. Note that I said it's an important step, but it's not the first step. There's quite a bit of formative work that needs to be done before you put a mobile lung cancer screening unit out on the road. In 2016, we were awarded a grant from the Patient Advocate Foundation to start establishing case management protocols with managed care organizations to increase lung cancer screening. And we quickly found out that even though lung cancer screening was approved as a population-based measure in high-risk patients, 3 years later, there was no infrastructure in our state. There were only five facilities on the lung cancer screening registry at that point in time. Our significant geographic barriers, coupled with low socioeconomic status and educational level of our patients, combined with limited provider knowledge of lung cancer screening, really meant that we were unable to establish those case management protocols and move forward with the project. We really needed to stop, take the time needed to develop the materials and the educational pieces to address both clinic, provider, and patient barriers. We methodically went through this process, developing and field testing materials before disseminating them. And then finally, as those materials were rolling out, we were able to engage the managed care organizations and other payers to increase statewide importance and emphasize that with our population so that we could bring lung cancer to the front of the focus for everyone. Another way of thinking about this and visualizing this journey is to look at the community engaged. So for primary care physicians, understanding that primary care physicians are the gatekeepers to lung cancer screening, really to all cancer screening. We learned early in 2016 through surveys and key informant interviews that the majority of our providers did not understand lung cancer eligibility guidelines, screening guidelines. They did not understand the process and the requirement for shared decision making. They did not know the CPT codes, where the referral sites were located, if the screening was covered by insurance. And as a result, they weren't referring patients for lung cancer screening. So we dove in, developed a bunch of education, and used a combination of modalities into delivering that information out into the primary care provider community. We coupled this with really a focus on community awareness to drive patient demand. So creating educational materials, conducting and putting out public service announcements, combining that with paid advertising, completing a bunch of one-on-one outreach and education at community events, and then engaging in a robust social media campaign helped us drive patient demand for lung cancer screening. While all of this work was happening, there was a dedicated group of professionals behind the scenes looking at and raising money to put a mobile lung cancer screening unit on the road. And so with that, I would like to introduce to you LUCAS. LUCAS is an acronym for lung cancer screening, and it is the only fully mobile AI-powered unit for low-dose lung cancer screening in the nation. It's going to travel statewide without the need for facility-based power. It's powered by a separate generator. This enables us to provide access to high-quality care. As you can see, we purchased a state-of-the-art 160 ultra-slice helical CT that provides the same quality of scan as our standing facilities. And when we were putting this together, through many conversations with various companies and the leadership team who was making the decisions, we really prioritized the fact that we wanted the lung cancer screening that was happening out in the community to match the service level, both in quality of scan and experience, as that in our facility-based sites. So in addition to the unit and the equipment, it takes a lot to put a lung cancer screening program on the road. There are startup costs that you have to deal with. It's a given that you have the scanning equipment, the tractor, the trailer. If you don't want to use shore-based power, you have to have a large generator, a truck to pull that generator, and about 5 years worth of operating costs. It takes about 5 years to the break-even point for cancer screening. And it goes without saying that cancer screening in and of itself is not a lucrative operation. And thinking about ongoing program costs and operating costs, you have to take into account personnel, and personnel really fall into 3 different buckets. The first is direct care. Those are the staff that actually interact with the patients on a day-to-day basis. We have program staff, and those program staff are important and key to communications with our clinic partners, communications with the general public, the supervision of the direct care staff. They are the people that make the program go. And then, of course, we have the behind-the-scenes staff, those staff that work when the scans come back to Morgantown. They have to be read. A certain amount of patient navigation has to happen. There's billing considerations. All of those behind-the-scenes staff fall into a different bucket. To be successful, I think it's important to know that philanthropy is a consideration. For us, we use philanthropy to focus on uninsured services, so we don't turn people away for an inability to pay. We work through raising money through philanthropy in our development office, as well as writing grants. And this is also a way to offset the cost of your startup equipment. For those of you who are the financial people in the room, you're probably thinking, this is a money loser. And for us, we view this more as a way of getting people through the front door. We can identify cancer when the human and economic costs of treating that disease are less. But also, it's important to think about return on investment. So for those folks who are worried about the bottom line, low-dose CT can identify a whole host of other medical issues that represent a steady flow of downstream service revenue that has to be taken into account when you're putting together a lung cancer screening program. I'll share a little story. When we started Bonnie's Bus in 2009, the director of radiology said, "I'm not sure why you're doing this. There's no money in cancer screening. There's no money in facility-based mammography, and you're going to have more overhead doing it on the road." And we said yes, but we were able to make the case to the institution that there's a value-added proposition to engaging in mobile screening. I will also share with you that after about 5 to 6 years, we have been able to meet costs and turn a profit to mobile mammography. So we anticipate, and the business model is set up for the same thing to happen with mobile lung cancer screening. But looking at that value-added piece, I think it's important to think about the intangibles of mobile lung cancer screening. Nowhere else do you have the opportunity of having a 50-foot roaming billboard that makes its way across the state. When WVU does market survey studies, what we found is that Bonnie's Bus is one of the most identified symbols of our institution, and that has increased every year since we started on the road. So there is value in having your name out and being seen across your catchment area. The other thing that we believe is that mobile screening is an investment in the health of our state, and that allows us to build both social and political capital. I think it's worth mentioning that WVU is an R01 land grant institution, and land grant institutions have a mission of service to the citizens of the state, and mobile screening allows us to fulfill part of that land grant mission. Additionally, being a research-focused institution, our mobile units serve as a platform for cancer research. It's a way of engaging sometimes a doubtful Appalachian population in clinical trials, even if those are primarily prevention focused. Being able to have a trusted mobile unit that people are used to seeing in the community, when you offer a trial, people are more willing to say yes. And finally, in summary, I think as we've moved from mobile mammography to a larger focus on mobile cancer control, Lucas becomes a cog in that wheel. And I share this summary graphic with you. I've covered most of the points as I've gone through the talk. But I share this graphic because we used it to tend to the details of putting a mobile unit on the road. And I thought I'd share it in case there are those of you who are interested in joining us on this adventure. I want to thank you again for the opportunity to share our journey to mobile lung cancer screening. Thank you.
Thank you, Dr. Lee and Dr. Kennedy Ray, for a great presentation today. We will now begin today's question and answer session. You can submit any questions you have by typing them into the Q&A chat box on your webinar console. Let's get started with the first question. So we've had several questions come in regarding insurance coverage and the new USPSTF recommendations. Could you clarify this for the audience, Dr. Lee?
Sure. Yeah, and it's confusing. I did mention it in my presentation, but it is confusing, so I'll go over it again. So I'll start off with the commercial payers. And under the Affordable Care Act, the commercial payers are mandated to cover lung cancer screening based on the USPSTF's Grade B recommendation that was originally put forth in 2013. And that's the ages 55 to 80, 30-pack year history of smoking, and either currently smoke or quit within the past 15 years. Now, earlier this spring, in March, the USPSTF revised their recommendations, again dropping the lower bound of age to 50, the lower bound of pack years to 20, but still keeping the 15 quit if they were a former smoker. However, they're not required to, commercial payers are not required to follow the new guidelines until 1 year after the new recommendations came out. So they came out in March 2021. They're officially not required to follow them until March 2022. But because most commercial plans follow the calendar year, we're really looking at January 2023, where they're actually required to cover lung cancer screening with the new guidelines without any cost sharing or copay to the patient. Now, anecdotally, we've heard that some insurance companies are actually covering the revised guidelines, but I think it's really more on a case-by-case basis and a plan-by-plan basis. So it's definitely recommended to reach out to your specific plan if you do fall under the new recommendations but not the old recommendations. And CMS is a completely different situation altogether. They're not mandated by the Affordable Care Act, so they have their own process. And so their recommendations came out originally in 2014, and that's the 55 to 77, again, 30-pack years, currently smoke or quit within the past 15 years. They're currently undergoing a review process to update those guidelines. A draft has come out, or I think it's about to come out, and it's going to undergo a review process with a comment period, but we should expect to see the new finalized CMS recommendations to come out, I believe, early next year, so early 2022. Now, unlike the commercial payers, as soon as the new CMS recommendations come out, they would be effective. So if they came out in February 2022 with new revised recommendations, those would be effective immediately.
In West Virginia, I can tell you that we've had a conversation with our largest private insurer, and they have made the change, but computer systems lag behind. So although the change is approved, it doesn't take effect until October. And they're telling us, though, if we screen people now, we can appeal and they'll pay for the screening. So I really do think it's an individualized conversation at this point with the private insurers until we hit that March 2022 deadline. Another participant asked a question about how could we work with insurers to get them to prioritize lung cancer screening? And the way I would answer that question is that establishing a working relationship with your state cancer coalitions, all 50 states have state cancer coalitions, and asking them to help you on this policy work would be beneficial. And also in some states, the American Cancer Society has staff who have priority work with payers. And so engaging those two bodies could be very helpful in moving this insurance question forward.
Totally. Thank you so much, Dr. Lee and Dr. Kennedy Ray, for kind of clarifying that for the audience and sharing what you've been seeing. The next question I have, and Dr. Kennedy Ray, I will direct this to you. How many patients does your lung cancer screening program screen in a year?
So as I mentioned in the presentation, our mobile lung cancer screening program just hit the road on September 8th.
But our plan is that we will screen about 3,000 people a year when we're fully up and running. With mobile programs, you start slow and build over time on the number of days that you're out and the number of patients that you screen per day. But we have our longest standing program in the state was established in 2017, and they screen about 1,000 patients per year, and that is replicated at other standing facilities across the state as well.
Thank you so much. The next question I have for you is just, with limited or no reimbursement for lung cancer screening programs, how does one build the financial justification for a program? Dr. Kennedy-Ray, can you grab this one as well?
Sure. I really think that lung cancer screening has to become part of the annual screening that's offered by health systems. As I mentioned in the presentation, this recommendation is not new, but uptake has really been slow. Like in West Virginia, we have a couple 100,000 people who are eligible for screening each year, and we're screening a fraction of that. As medical centers have the opportunity to change this trajectory in the disease by engaging in robust screening, low-dose screening will dramatically shift the lung cancer stage at which cancer is diagnosed, and then that becomes less costly to treat. And although the reimbursement rates are somewhat low for low-dose CT, it's fairly comparable when we look at screening tests like mammography. But what we know about low-dose CT is that the test identifies other medical issues, including moderate and severe coronary artery disease and other cardiovascular issues, and this generates downstream revenue. The business model has to take this into account. Additionally, billing CMS for shared decision-making for all patients and tobacco cessation assessment and referral for those patients who are smoking will generate some additional revenue.
Thank you, Dr. Kennedy-Ray. So we have a few more minutes, so I'll try to get through a couple more questions. The next one I have is for you, Dr. Lee. And the audience member says, WVU's program targets a rural population. Is there a similar opportunity to improve access to eligible patients in an urban environment?
Sure, and over here at Cedars-Sinai in Los Angeles, we are actually starting to explore the possibility or idea of having a mobile program. But as you can imagine, Southern California is probably as different as you can get in West Virginia. If you just take our county, Los Angeles County, for example, our population is more than 10 million, so more than 5 times the entire state of West Virginia. And one of the biggest consequences, as you can imagine, of this density is the traffic. And during certain times of the day, it can take up to an hour to drive 10 miles. And so as a result, people in LA generally don't like to leave their neighborhoods unless absolutely necessary. One of our catchment areas actually is an area north of Cedars-Sinai called the Antelope Valley. It's about 65 miles north of the hospital, and so that can take more than 2 hours to drive in heavy traffic. And the closest lung cancer screening center to this region, Antelope Valley region, is actually more than 30 miles away. So even in a populated portion of the state, such as Southern California, I think there are still very real access issues that can potentially be mitigated with a mobile screening program.
Totally. Thank you so much, Dr. Lee. The next question I have is just, what are some of the key challenges in scaling up a lung cancer screening program? Should adoption take off? And Dr. Kennedy-Ray, can you grab this first?
I'll start and then Dr. Lee can finish up. I think, honestly, the sheer number of those eligible to screen can present challenges. Additional considerations for mobile include that we are looking for personnel who have a unique set of skills to thrive in a mobile workplace. It's not for everybody. We are looking for people who are flexible, who have strong problem-solving skills, who love community-based work, and there must be a willingness to embrace non-traditional work hours, and that can be a challenge in today's work climate. It's also important to note that as we went through the build process for the mobile unit, and the needed generators to make that run, we experienced some supply chain issues. So for those folks who are thinking that they want to go outside the box, build in enough time to make sure that you can obtain all the parts and pieces that you need. Dr. Lee, what do you think at Cedars? What are some of the issues in scaling up?
Yeah, I think, again, just kind of broadly speaking, the volume is definitely going to be the biggest issue, especially now that we know with the new USPSTF recommendations are effectively doubling the eligible lung cancer screening population in the country. So most programs, as they get started, they start off with one navigator who's responsible for recording the CT results and arranging follow-up. That can be as simple as an annual CT scan, but as you know, it may also include a 6-month follow-up scan, a 3-month follow-up scan, or a biopsy or specialist deferral for a lung RADS 4B or 4X lesion. And furthermore, the navigator may also be tasked to arrange follow-up appointments or tests for the various significant incidental findings that you mentioned that can be discovered in LDCT. So as you can imagine, things can start to get pretty crazy for a single navigator to handle, especially if he or she is tracking all the patients on Excel spreadsheets. So I think as a result, programs who are really expecting a quick ramp up in volume really need to invest in some type of software, tracking software. Fortunately, there are a number out there offered by various vendors, and this can assist in tracking patients, automatically setting the follow-up dates for the LDCTs based on the lung RADS category, also automatic patient letter generation. And so I think really that's going to be a key component to have in place if you're expecting any kind of volume.
That is unfortunately all the time we have for today. I want to thank our speakers for an excellent presentation and Canon Medical Systems for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you for joining us today, and we hope you have a wonderful afternoon.